This is Dr. Sargsyan, and we will talk today about fluids and electrolytes, acids and bases. To start this topic, I would like to touch base about the notion of total body water. You know from the literature and from colloquial evidence that a human body is, most of it is water. So when we're talking about total body water, we are considering that about 60% of the body weight in adult person is water. What that water comes from, it comes from sum of all fluids within all body compartments. That will be total body water. Common misconception, consider it intravascular water, intravascular fluid, which is not right. Again, it's the sum of fluids of all body compartment. So the volume of total body water is a percentage of body weight in kilograms. Just to touch base here, we all know that 1 kilogram is 2.2 pounds, and we will go again in this course by using kilograms. What's the rest of the body? What's the rest of the body weight? The rest of the body weight comes from fat-free solids, and when we say fat-free solids, we are not talking about yogurt, but we are talking about bone. What type of fluids we have in the body? Intracellular fluid, extracellular, and interstitial, which is also part of interstitial, is part of extracellular. Intravascular fluid, also different types of fluids such as lymph, synovial, biliary, hepatic, pancreatic, cerebrospinal, pericardial, peritoneal. You have your pleural space, pleural fluid, even the eyes, intraocular fluid. One of the most difficult concepts to master, but I'm sure we can do it in this course, that the fluid in intercellular spaces can be called interstitial spaces. So what's in that fluid? It's water, amino acids, some type of sugars, glucose, enzymes, hormones, neurotransmitters, salts, anything else like any cellular products, fatty acids. So these fluids surrounds the cells of the body, and this fluid is some type of communication channel. It's not really a channel like a network, but it's the surrounding gives you an option to deliver materials to the cell, and also important point again, your intracellular communication and removal of the waste. I'd like to talk in this course a lot about intracellular communication because again, human pathophysiology, we are talking about multicellular organisms, not unicellular. So again, one of the most difficult concepts is interstitial fluid, so-called third space. And this third space fluid allows means of communications and means of delivery of certain materials or compounds to the cells. And when you have delivery to some place, you also have waste removal. And by waste, we mean metabolic waste. Intravascular fluids or fluids within vascular space, and again intracellular fluid, it's completely opposite location. So you have this compartments of fluids, and the most distinct one is intracellular. Everything else is extracellular, which you can subdivide into third space or interstitial fluid, intravascular, and all small or relatively small compartments I was talking about, which located in their spaces, such as lymph node, such as lymphatic fluid, synovial, cerebrospinal, even sweat or urine still consider, if it's in the body, it's considered extracellular fluid. We know that it won't hang around there for good for a long time, but it's still inside of the body. This is still extracellular fluid. Even fluid inside of the eyes, pericardial, pleural, peritoneal, all these types of fluids, it's all extracellular. So to distinguish, know the difference between intracellular and extracellular. Water moves between intracellular and extracellular fluids. So what happens here, we are again getting to the concept of semi-permeable membrane, which we all know from early childhood. At least some of us do, but most of us, we learned about this in physics courses, chemistry courses, and our nursing foundational courses, med-surg, and everywhere else. So we know about this. But what's the concept in this? What's the main thing to help you remember? You have to remember this: salt loves water, and this will help you a lot in your professional life. Salt loves water. Salty part will attract salty compartment, or compartment have a lot of solute, not solvent, solute will attract water into it. What's happening? Both compartments trying to equalize. So the concentrations try to get equal. Will it get equal or not? We don't know, and most of the time no. But salty compartment will try to draw the fluid into it. And by salty compartment, we're talking about solute. So example, you are giving hypertonic solution into your intravascular space, and hypertonic has lots of salt dissolved, so it will draw lots of water into it and dehydrate the cells. If you give hypotonic solution, you are putting your patient at risk of swelling of the cell, and swelling in the cells in the brain in particular and everywhere else. So you can have hemolytic anemia by the means, not really an anemia, but you will have destruction of or hemolysis of the red blood cells by them swelling with water, because concentration of salt or solute inside of the cell is much higher versus the concentration of the intravascular fluid per se. So they will burst. Same will happen with the brain. Besides of the bursting, the swelling itself in the brain will result in brainstem herniation. So please, I know this is review, and I know you all have knowledge of it, so please spread the word. Don't give anyone hypotonic solution unless it's indicated for one or the other reason. Hypotonic solutions are basically evil unless it's indicated for this person. So Starling hypothesis, or another way to put this is a Starling law, is describing the concept of net filtration. And net filtration, to understand this, net filtration means where the fluid will move and how much fluid will you have in that compartment. So net filtration equals forces favoring filtration minus forces opposing filtration. So this will show where the fluid will move. Starling hypothesis talking about net filtration. By forces favoring filtration, we will consider several forces such as capillary hydrostatic pressure, pressure in the pipe. You going home and opening your faucet and trying to cook dinner after a long day, and you are using hydrostatic pressure, basically pressure that tries to push water out of the pipe, or blood pressure in this case. Interstitial oncotic pressure is another force that favors filtration. What is interstitial oncotic pressure? It's the water pulling pressure. It's the water pulling force that encourages the water get into the compartment that is saltier, that has more solute. So from one side, your blood pressure will try to push out outside of capillaries your fluids, and on the other side, the saltiness of the, let's say, cells, or salt or solute concentration within the cells will aid by osmotic or oncotic pressure trying to pull more into the cells. Forces favoring reabsorption, it's plasma oncotic pressure. So we still have osmosis here, but we are concerned about the concentration of salt inside the vessel, inside of your intravascular space, and it will pull water in. Another one is interstitial hydrostatic pressure. Interstitial hydrostatic pressure is the same way like your pipes, like imagine your cell is a pipe, or whatever that surrounds the vessel or capillary is a pipe that tries to push the water in. So to summarize this, remember, hydrostatic pressure is the pressure of the pipe. It tries to push out the water because we pressurized it. Oncotic pressure is happening because of the concept or phenomenon of osmosis. The compartment of higher concentration of solute tries to pull the water into it, and even the concentration between two compartments. The key point, the cornerstone here, again, the compartments are divided by semi-permeable membrane. Semi-permeable membrane means that your membrane is selectively permeable. In this case means the small particles like water molecules will pass through, but larger particles they won't, such as big proteins or dissolved salts and electrolytes, that type of things. But again, large particles have misfortune of staying in their compartment, while water can pass back and forth and create the oncotic pressure. Accumulation of the fluid in interstitial spaces can be extremely dangerous, and what I'm talking about, of course, is edema. What can cause it? So first of all, think about increase about hydrostatic pressure. That can definitely increase the accumulation of the fluid in interstitial space, and by hydrostatic pressure I mean in the capillaries. Your capillaries are overfilled and trying to give out as much water as they can. Okay. Well, what about oncotic pressure? We remember from the previous material that your intravascular fluid has oncotic pressure, of course, and oncotic pressure of intravascular fluid is the force that goes from outside of the vessel towards the inside of the vessel. What's inside of the vessel? Okay, we know that salts are dissolved, but here we're coming to this most important concept of albumin. Albumin produced by liver, one of the proteins. Albumin can signify the liver dysfunction, and at this point when we have diminished or no production or even destruction of albumin, the edema may occur. Without albumin, your capillary space does not have enough force, oncotic pressure to pull the water out of the cells. So that's why they would go, or interstitial spaces in this case. That's why they would go out of the vessels and lodge somewhere. And yes, edema is accumulation in interstitial spaces. And yes, low albumin will cause this. Low albumin will cause swelling and edema. That's why your patients with liver failure always, well, not always, but very often may have lower extremity edema or even generalized edema. Another type of edema is lymphedema, when lymphatic network gets obstructed and there is no way to drain out lymphatic fuel. There is no way to drain out lymphatic fluid. Lymphatic obstruction causes the lymphedema, and the examples are some type of surgery, manipulation with lymphatic vessels, nodes, and this all can cause lymphedema. The last one I want to mention is your capillary permeability is increased, so fluids just spill out of the capillaries. This works in conjunction with hydrostatic pressure, but what happens if capillary permeability is increased? You don't need significant hydrostatic pressure to push the fluid out of the vessel to interstitial place. So this means that your hydrostatic pressure may be fairly normal, but if your capillaries are very permeable, that means even normal pressure will create edema. Water balance is regulated by several mechanisms. Thirst perception is very complex mechanism, and it seems simple. If someone is thirsty, they just drink their water or drink of choice and they feel better. But in reality, the mechanics, the logistics of this are very complex. While we're talking about it, we need to touch base on hyperosmolarity. So when the osmolarity increases, what will happen? What will be affected? Where are these receptors? Okay, so we're talking about receptors. We need to name them, and we'll name them osmoreceptors. Are they located all over the place? No, they are located in hypothalamus. So it's hypothalamic osmoreceptor. So this will cause sensation of thirst. Also, what these osmoreceptors would do, they will send a signal to posterior pituitary to release one of my favorite hormones, because it's so interesting to learn about it, but again, it's not about my favorite hormones, and it's about releasing ADH, and ADH is antidiuretic hormones. So antidiuretic stops the diuresis. Thirst will start stimulating the patient to think about lack of water, will create desire to drink water, and person will eventually drink. ADH at the same time will increase the water reabsorption into the plasma. And of course, all of this happens in distal tubules and collecting ducts of the kidney. But the main point is ADH will help to reabsorb, antidiuretic. So the reabsorbed water will decrease the osmolarity, will go back to normal, and I guess that's fine, but you have another thing here going on. What will happen with the urine? And urine concentration will increase. So it will become more concentrated, more darker. Not more darker, but just darker, and it will be the sign of possible dehydration. When dehydration occurs, when the organism or the person is losing lots of fluid, and the causes can be numerous and seemingly insignificant, like sweating, but still by excessive sweating person can lose lots of fluids, or patient can have gastrointestinal distress resulting in vomiting, diarrhea, or blood loss, literally just losing the fluid through the blood. The baroreceptors kick in. So this is the second mechanism of water balance regulation, the baroreceptors. Baroreceptors are barometers. They are pressure sensitive. These are nerve endings that will signify, that will be affected by changes in pressure. At the same time, they also will be affected by changes in volume. This also goes to pituitary gland, and of course posterior pituitary, to mention it again, and simulates the release of ADH. Okay, where are these volume receptors located? They located in, again, not all over the place, but volume receptors or baroreceptors of volume type, they are located in the right and left atria and thoracic vessels. So in thoracic vessels such as aorta, pulmonary arteries, also they can be located in carotid sinuses. ADH is important player in this entire process. It can also increase, or secretion of it can start when atrial pressure drops. And what's the main reason your atrial pressure would drop with fairly rapidly? Like, let's say a stab wound or something, the major vessel is severed, or and in this case the pressure drops, and pressure drops because of the decreased blood volume secondary to blood loss. So at this point, the reabsorption of water will be governed by ADH, which will try to promote the increases plasma volume, and by plasma volume is really our goal is to maintain not just volume but a perfusion and maintain significant blood pressure or relevant sufficient blood pressure, which all of this will result to hopefully restoring the water balance. At this point, we'll realize that if the losses are significant, even this protective mechanism may not work, but if the reversal of the process possible, of course this will work, of course this will kick in and will restore the water balance. So to summarize, there are two parts of water balance restoration, and thirst perception regulated by osmoreceptors in hypothalamus, and the second is baroreceptors stimulated by plasma volume depletion. this is all very simple concept. However, there are several small steps in it. That's why I took time to go over it. And if you have questions, please contact me. I would love to talk about this more and more. Sodium and chloride balance. This is our favorite table salt. As primary care providers, nurses, we always encourage patients not to overeat the salt. But before we go to that point, why we don't like our patient eating salt a lot, let's just give a simple overview of this. Sodium and chloride, most of the time they go together. Sodium is primary extracellular fluid, and again, just to review, intracellular is, of course, I see the imaginary class yelling potassium, and you guys are right, as usually. So sodium will regulate osmotic forces, right? Like I keep saying, salt loves water, and the salt is sodium. What else it can do? It can regulate acid-base balance, cellular reaction, neuromuscular processes may happen, may be regulated, and neuromuscular irritability in particular is dependent on sodium. Chloride, again, in extracellular fluid, its extracellular anion provides a mean to neutralize the sodium, not neutralize like make sodium neutrally charged, but it balances the charge of sodium. So it's always should correspond each other, sodium and chloride balance. Sodium and chloride balance is at the same time very complex mechanism and regulated by several hormonal processes, hormone releases, and we know from the previous parts of our pathophysiology, anatomy and physiology, and nursing courses, renin, angiotensin, aldosterone system, and aldosterone role in it. So I won't be spending much time on this, and we'll talk about this about when patient is diagnosed with hypertension. However, the balance also regulated by natriuretic peptides. Natriuretic peptides are, of course, hormones. They produced by several organs, and there is arterial natriuretic hormone, and again, this is all based on location, so it's produced by myocardial atria, and I said arterial, it's atrial, I'm sorry. Brain natriuretic peptide is BMP, and it's produced by myocardial ventricles, and urodilantin is synthesized or produced by kidney. So all three of these are produced within the body to regulate sodium and chloride balance. A side note here, atrial natriuretic hormone is really similar to urodilantin. It's just the place of production is different. Urodilantin is in kidney, and ANH is a atrial production. So these peptides will come out when pressure increases. And what type of pressure I'm talking about here? It's atrial pressure. Atrial pressure will be a consequence of increased plasma volume, And what's the most common occurrence here can contribute to atrial pressure increase? There are a number of different scenarios, but the most common one is again congestive heart failure, or also, of course, less common or fairly common is increase in mean arterial pressure. So heart is failing to pump and atrial pressure increases. This is fairly clear-cut. And overall increase in pressure, we don't know why, or we know why, but we don't want to talk about it, also will result in the natriuretic peptides production. So these peptides will cause vasodilation. That's how they work, and they will increase sodium and water release or exertion, which will result in blood pressure decrease. Sometimes these natriuretic peptides are called as a so-called third factor, and by third factor we mean there are two other factors that regulate this. And what's the most common factor here? Of course, what regulates the sodium balance most commonly is, of course, glomerular filtration rate and aldosterone, renin-angiotensin aldosterone system is the second. So a role of natriuretic peptides and the discovery of their properties is continuing to fascinate the scientists, and actually they have practical applications as cardiac drugs, to combat the heart failure and to introduce the vasodilation and sodium and water exertion. Basically, you can use it as diuretic. Most common drug is Natricor, and it mimics BNP. BNP is also one of the labs you can draw when you are suspecting a congestive heart failure in your patient, and the increase in BNP is highly suggestive that yes, there is a atrial pressure increase, and most likely this is CHF specific. Alterations in sodium and chloride and water volume balance can be isotonic. Basically, when we're having isotonic alteration, body just loses water with proportional electrolyte change, isotonic volume depletion, and isotonic volume excess. So all of these moving, sodium chlorides and water moves at the same time. So we don't really lose one and keeping the other. So that what I'm trying to say here, that's the tonicity of the fluid may stay the same in this case because we're losing proportional amount of water, and we are losing a proportional amount sodium and chloride. When we're talking about hypertonic alterations, of course, this is called hypernatremia, secondary to increase of sodium, and this can happen two ways: either increase of sodium concentration or water loss. So water loss can be also like a water movement from intracellular fluid to extracellular fluid, and which will cause intracellular dehydration. So what will be the presentation of this patient? when we're having hypernatremia. Presentation can be very wide range from, as I mentioned, intracellular dehydration, convulsions, seizures, pulmonary edema, hypotension can happen. This also can be manifested as tachycardia as a compensatory mechanism. So if we're having water loss. So hypernatremia again is one of the hypertonic alterations in a body you can observe, and hypernatremia, of course, hypertonic because it's higher concentration of the sodium. So the last thing to say in here is that concentration of the sodium more than 147 milliequivalent of liter considered hypernatremia. Hypertonic alterations secondary to water deficits can be described as a manifestation of dehydration, or also can happen just as pure water deficits, means renal free water clearance affected. Dehydration happens when water is deficient. Also, term dehydration can be used when it's concurrent loss of water and sodium. So this will be isotonic or isoosmolar dehydration. Basically, as I was saying before, all of sodium chloride and water is lost, so it's isotonic. Okay. When we're comparing is to pure water deficits, then we're having a difference here that the concentration of salt at this point here, concentration of sodium chloride is not changing. So pure water deficit is hyperosmolar or hypertonic dehydration. And if you think about it, when you lose water, when you will most certainly lose electrolytes as well, and this type of imbalances like pure water deficit is very rare. And most of the time this is someone who is comatose and somehow they lose water through the skin or through the respiration, through lungs, and the hyperventilation caused by fever can result in water deficit. So another reason, and that can be the most common reason of water loss, is increased renal clearance of free water, and this is always a result of impaired tubular function. Or just to remember this better, this is inability to concentrate the urine, and if we cannot concentrate the urine, we may be missing antidiuretic hormone. So diabetes insipidus, when we don't have enough antidiuretic hormone, can be resulting in a pure water deficit. So again, when we're talking about it, please distinguish between these last two causes I talked about. It's increased renal clearance of water as a result of tubular function impairment, or for some reason inability to concentrate the urine. And number two is inability to concentrate urine or excessive diuresis secondary to decreased antidiuretic hormone, and the condition calls diabetes insipidus. This has absolutely nothing to do with blood glucose concentration and pancreas, although it's again called diabetes insipidus. But don't fall into this easy trap that whoever creates the exam for you, or on any board exams, you may meet this quite common question to see the difference between diabetes insipidus and diabetes mellitus. Let's continue talking about electrolyte imbalances and anion imbalance, such as hyperkalemia. Again, chloride follows sodium, so as I talked about it previously, so you have to have hyperkalemia with hypernatremia. Also, this is another option of dealing with bicarb deficits, and we will have excess of the chloride. Some type of pathophysiologic process may occur, and again, chloride deficiencies alone are quite rare or not common. So the best thing to correct it is to treat the underlying disorder. Hypotonic alterations. Hypotonic means osmolarity decreased. Again, like I said, hyponatremia or free water excess. So when we're talking about hyponatremia, the extracellular fluid osmotic pressure decreased, and water will move into the cells. And this is one of my pet peeves. Hypertonic alterations, of course, can be very deadly and have very dramatic effect for the patient, and have a sequela of brain herniation. And basically, until that dramatic sequela occurs, and hopefully it won't, it will be corrected by that time, water movement will cause the symptoms secondary to hypovolemia. Basically, you will have decreased intravascular fluid because all of your fluid, not all, but significant amount of your fluid moved into the cells. And another negative consequence of this is the cells bursting, and you will have destruction of red blood cells if it's not corrected. Hyponatremia, considered when the levels of the sodium drop below 135, and so normal range, we can say it's 135 to 147. Some labs would say 135 to 145. Again, sodium causes hypoosmolarity of plasma and cellular swelling. Several causes of this: sodium deficits, unlikely in this day and age with high consumption or high salt content of most of the products you buy in the grocery store, especially prepackaged or pre-manufactured or microwavable. So, but still, low intake of sodium can result in hyponatremia. The other more important and more dramatic ones are dilutional hyponatremia, when you have excess water, hypoosmolar, and hypertonic hyponatremias. Hypotonic alterations are related to water excess, and this is an important point to know that water can be very dangerous and poisonous, not all as a swimming or drowning hazard, but also as a result of compulsive or excessive water drinking. It can be a result of psychiatric illness. Patient will continue feeling or believing that they're missing water, or they dehydrated, or for some other reason related to psychiatric disorder. B, and more you see the reports of fraternity hazing with water, or even there was a report of radio station having a content who will drink more water, which resulted in a death of the listener. Again, I'm not going into the details where it happened and how, but for you to know, water excess can be deadly. And besides the increased oral intake of the water, we can talk about inappropriate ADH, syndrome of inappropriate antidiuretic ADH. Inappropriate in physiology or pathophysiology content is equivalent of excessive. Every time you see inappropriate, you know that is excessive. So inappropriate doesn't mean that ADH has obscene behavior and was appearing in Facebook in pictures that you don't share, but this means that there is too much of ADH. ADH secretion in the absence of hypovolemia or hyperosmolarity. So what will happen in this case? The cerebral edema, muscle twitching, headaches, weight gain, of course, secondary to retention of water. But again, most common or fairly common, again, origin of this can be some kind of posterior pituitary dysfunction, or even a tumor secreting this. Hypokalemia is a result of hyponatremia. Again, chloride and sodium go together, and as I said, it's bicarb concentration increase. It will develop when electrolyte loss is imminent, such as vomiting. And vomiting affects the loss of hydrochloric acid from the stomach, and this can present with significant sequela because of that. Most of the other causes of chloride loss is fairly benign compared to this, and usually resulted to a concurrent loss of sodium. But again, in vomiting, the loss of hydrochloric acid may be the dramatic and significant event that will result in hypokalemia. Another syndrome or another disease, this can happen, of course, cystic fibrosis, and we'll talk about it when we talk about cystic fibrosis. Talking about potassium, needless to say at this point, we all know that it's the major cation found inside of the cells. And just a brief review, that concentration will be maintained by sodium-potassium pump. The regulation of the the regulation of potassium can be related to insulin levels, and also potassium will regulate intracellular electrical neutrality in relation to sodium and proton or acidity. So why we need potassium? Because it's needed for conduction of nerve impulses, to maintain normal cardiac contraction and rhythms, and also skeletal and smooth, let's say, GI muscle contraction. All of these governed by potassium. That's why it's important to provide a concentration of potassium that's fairly small segment, in very small interval, and we have to maintain it. Otherwise, it may result in several profound dysfunctions, and to name the most profound is cardiac arrhythmias and even death. Potassium levels can be affected by changes in pH, and that may affect potassium balance. So when hydrogen ions will accumulate in intracellular fluid during acidosis, when body is acidotic, potassium will go out or shift out from inside of the cell to balance the cations across the membrane. So again, this will be a consequence of acidosis. So aldosterone, insulin, and catecholamines will regulate or influence potassium levels. So to talk about insulin, this is very important concept, and sometimes it's overlooked because we talk about insulin as an agent to treat diabetes. However, this is an important drug to treat potassium dysfunction. Insulin will increase the permeability of cells to potassium, as well as magnesium and phosphate, of course, but we are talking about potassium here. The effect of potassium here is the one that's clinically important, the one we concern. So what happens? Insulin will activate the sodium-potassium ATPase in many cells, and it will allow an influx of potassium into the cell. So think about it. We all know that insulin is a dangerous drug or high-risk medication, but we're always thinking about hypoglycemia. On the other hand, injection of excessive amount of insulin may be deadly because of its ability to decrease plasma concentration of potassium. On the other hand, this may be an agent to treat excessive potassium concentration. Hyperkalemia is when the level of potassium drops below 3.5 milliequivalents in a liter, and we can name several causes of this. So again, intake of potassium reduced. Again, increased potassium entry into the cells, and again, increased potassium loss. So when we're talking about electrolytes, there are two themes you hear over and over again. It's the loss when we're talking about some type of hyperkalemia or hyponatremia. Intake, so you don't get enough. And on the other hand, potassium is quite unique because increased potassium entry into the cell can, of course, result in hyperkalemia. What will happen if we're having low potassium level? The cellular membrane hyperpolarizes, and it will cause the neuromuscular excitability decrease. So when we're saying neuromuscular excitability decreased, we mean that the patient will have the weakness of skeletal muscle, and if they are weak, they cannot move it, and if they have been exposed to hyperkalemia for a long time, they will have smooth muscle atrophy because they don't move it. And the most urgent one, in this case hyperkalemia, smooth muscle atrophy will take a long time to develop, right? But what will develop right away or fairly fast is cardiac dysrhythmias. Hyperkalemia, on the other hand, is potassium excess, more than 5.5 milliequivalent a liter. So from 3.5 to 5.5, this is your normal range. Again, depends on the lab, 3.5 to 5.0, 5.1, 5.2. Again, this is all relative. It will giving you a range. When we're talking about lab values, we have to consider the lab ranges your lab entity you choose for your results provides you with their norms, but also you may consider the references you learned in your education. Hyperkalemia is relatively rare deficit because we all remember working in the hospital will pump the patients with these bags with added potassium, or even you can give potassium injections, of course not concentrated, or by injection I mean intravenous drips. And but treating hyperkalemia is fairly rare event in the hospital setting, but some of us did treat it, yeah. And what's causing this? So again, let's think about shifts. Let's think about shifts from, so shift from intracellular fluid will occur to extracellular for one or the other reason. Okay, potassium isn't excreted enough from renal. Oh, and again, insulin comes to play, and insulin deficiency can cause this. Cell trauma, cells burst and release lots of potassium into intravascular space, circulation. And one of the fairly common potassium level increase sources is either potassium poisoning, or when patient for one or the other reason takes excessive potassium supplement. And this is, we are entering into a completely different venue when patient forgets, or it can be intentional poisoning with potassium. Also, also another option is your patient will have hyperkalemia. It's part of the lethal injection, or at least in some states the artificially induced hyperkalemia, and will result, of course, in cardiac arrest. Hyperkalemia, when it's mild, it will result in hyperpolarization of the cellular membrane. And again, if we hyperpolarized it, then our neuromuscular irritation or irritability will increase. So patient will complain of tingling of lips or fingers. They sometimes may describe it as paresthesia, but it's really tingling sensation. Patient may be restless, have cramping, and also may have cramping in their abdomen, or is intestinal cramping. Increased peristalsis and diarrhea. So hopefully we can correct all of this, but when we enter into a severe state of hyperkalemia, the cells will not be able to repolarize, resulting in muscle weakness. So from irritability increased, we are losing the ability to repolarize, and we're losing muscle tone, and we are getting into state of flaccid paralysis and cardiac arrest. So this is what I was saying previously. Excessive potassium can certainly be deadly and can certainly used as a lethal injection. But as nurses, we prefer to treat the abnormal conditions, not to induce them. So what will we do for treatment? Calcium gluconate can restore the neuromuscular irritability when the potassium levels are high. But this is some type of a little bit temporary solution, because you're still not dealing with serum potassium levels, especially if it's the decreased exertion takes place, decreased renal exertion, then we just putting a little band-aids on the problem. How to deal with it like profoundly and just fix it for good, at least for a long time. So we can actually administer glucose if patient can produce their own insulin. If we administer glucose, patient will have a boost in insulin, which will cause the movement of potassium to intracellular space. But if you kind of in doubt that patient can produce insulin, or you know that your patient has diabetes, especially type 1, you know they don't produce their own, so you can give just insulin, and which will facilitate cellular entry of potassium. Of course, at that point, you have to monitor the glucose level and not to induce profound hypoglycemia. Another reason, as I was talking, the correlation between potassium and hydrogen ion concentration, but another reason of this of hyperkalemia can be acidosis related. So to fix our acidosis, we'll proceed with administering bicarb, bicarb that everyone says in the hospital, but it's sodium bicarbonate to correct metabolic acidosis and lower at the same time sodium potassium concentration. One of the most common options you will see done, it's administration of cation exchange resins, and it's famous kioxalate with exchange sodium for potassium in the intestine, and it can be effective. Kioxalate can be given orally and also rectally to produce these effects, but it's a relatively well researched method, and it's most of the time it's very effective. Calcium is another cation I would like to talk about, and of course calcium is located in the bone, and most calcium in the bone is located as hydroxyapatite. Calcium needed for maintaining the structure of the bone and teeth. Maintain the clotting, as you know, it has significant role in clotting cascade, hormonal secretion, and cell receptor functions also will be regulated by calcium. Phosphate is another anion that's located in the bone, and calcium and phosphate go together. And most of the phosphate, approximately 85%, located in the bone. We need phosphate for high energy bonds located in creatine phosphate and ATP, and phosphate will act as well as an anion buffer. Okay. So as I said, calcium and phosphate are very tight together, and calcium and phosphate concentrations are rigidly controlled and by this equation. So calcium and phosphate concentrations multiple is a constant. If concentration of one increases, the concentration of the other decreases, and K here is a constant. Calcium and phosphate are regulated by three hormones. Parathyroid hormone, or PTH, will increase plasma calcium levels via bone reabsorption, and vitamin D, it's really a fat-soluble steroid. It's one of the fat-soluble vitamins. It will increase calcium absorption from GI intact, from food intake, and calcitonin will directly affect plasma calcium levels and will decrease it. When calcium concentration drops less than 8.5, hypocalcemia occurs, and there are several causes for that, like deficit in the calcium, or maybe related to inadequate absorption in the gut. And ionized calcium will be deposited, on the other hand, into the bone or soft tissue. You see all these calcifications in the soft tissue sometimes. Blood administration can cause it, or decrease in PTH and vitamin D. So nutritional deficiencies, if patient has inadequate consumption of calcium-containing products, it's definitely will affect the calcium levels. Blood transfusion, I mentioned, it can be a common cause of hypocalcemia, not because the blood by itself affects it by any way, but because the blood is infused or stored, I would say, in the bag in a citrate solution, and that will bind with calcium. So another cause, of course, is pancreatitis. If the lipase goes into the soft tissue space, the fatty acids can bind with calcium, and when lipase goes basically into soft tissue space, it contributes to formation of the free fatty acids that are looking to bind with something, and they will bind with calcium, and again that will decrease the level of ionized calcium. One of the ways, by the way, to diagnose pancreatitis and see what happens, not the most direct way and not the most significant, but it will help to establish your diagnosis, the lower levels of calcium, and again that's secondary to lipase. So vitamin D deficiency can happen, again ultraviolet radiation absence, how cautious are people nowadays, and also fat deficiency in the diet or malabsorption of the fat. This can be numbers of reasons to contribute to this, from the psychiatric disorders versus malabsorption secondary to absence of pancreatic enzymes. Another option for this is when a patient has destruction or removal of parathyroid gland. Parathyroid hormone deficiency can result in hypocalcemia. So there are numerous sources to cause this, and the results will be that neuromuscular excitability will increase secondary to hypocalcemia. So there are two signs, Chvostek and Trousseau sign, and rare occurrence again. Not every patient with hypocalcemia will develop this, even with significant hypocalcemia, but you can elicit Chvostek sign by tapping on the facial nerve of this patient, and just to find where it is, just tap below the temple. The twitching, uncontrolled twitching of nose of the lip will occur, and what you do, you just irritate the facial nerve and you inducing response, nerve response. The Trousseau sign is the contraction of the hand and finger when blood flow to the extremity and to the hand, not the entire extremity, is occluded. Usually the use of blood pressure cuff is recommended to induce this. But again, these two signs are the remnants of the old school, of old traditional medicine, mostly intuitive when the lab results weren't available. Because if your patient even exhibiting those signs, your goal is to find out how much actually calcium is lacking, what's the number of calcium. So the treatment for this will be to replace the calcium in emergency situation. An emergency situation when patient presents with tetany, and tetany is like severe muscle spasm, and by muscle spasm we mean severe contractions of entire body, and most of it we're concerned about respiratory arrest and that. So at this point we can administer calcium gluconate intravenously as an emergency measure. If the calcium levels aren't that low and patient is doing well, overall the oral calcium supplements can be given. Some advocate to give oral calcium as a citrate, and there is a body of research suggesting that the citrate will be more efficient than, let's say, calcium carbonate that you can find in Tums. So decreasing phosphate intake also can be one of the ways to manage hypocalcemia long term. Hyperkalemia. So everything happens the opposite way. So the blocking of the sodium into the cell increases. The neuromuscular excitability decreases. Muscle will be weak. Okay, then it's getting even worse because patients with hyperkalemia will experience bone fractures and kidney stones and constipation because of this. And again, constipation obviously is a result of hyperkalemia and the result of decreased muscle tone in the gut. So how to treat? First of all, you need to evaluate before treating, and you won't be able to elicit any of the signs like Chvostek and Trousseau sign, but at the same time you can truly diagnose this based on your lab results. And again, depending on severity, you may proceed with oral phosphate administration. Remember, the phosphate components are only indicated when renal function is normal, and if you read the solid deodorant packaging, it's a consult with physician if you have renal disease. That's what, because the deodorant may contain phosphate, and that's what can affect the patient or whoever, the consumer. But treatment options will include normal saline administration, IV, and basically to dilute, and also another way to deal with it to administer calcitonin to regulate it. But to treat this and to understand this, hypercalcemia doesn't occur by itself. It occurs secondary to some cause, and one of the causes also can be the parathyroid will be overly active or have tumor and have parathyroid hormone excess. I remember a clinical case from last year. We had a patient with history of parathyroid tumor, which resulted in complete thyroid removal for this lady, and of course parathyroid too. And she was receiving the parathyroid supplements. When she was receiving parathyroid supplements, it resulted in a crisis with the increased calcium in the plasma, with all the consequences, which was corrected with calcitonin. We met her on her next admission, and we faced the opposite problem, and she had multiple other disorders like multifactorial, but at this time her calcium levels were very low. And this is the first time I seen the actual Chvostek and Tresocine induced. So at this time, patient became progressively worse and start having slurring of the speech and start exhibiting tetany. And the solution was to the condition to administer to administer intravenous calcium gluconate to deal with this condition. Again, this case is fairly clear-cut. It's absence of parathyroid, and the regulation of it was done by artificial means. By regulation of parathyroid hormone was done by artificial means, and hopefully eventually she will be in the normal range and the consequences won't happen. But until then, she had these two crisis situations on two different admissions, which were promptly taken care of. But it was especially the one we witnessed with tetany and slurring of the speech, and both signs positive. It was quite dramatic and quite significant for the patient herself. But as far as I know, she did well, and she was discharged and never came back to the hospital. When we're talking about hyperphosphatemia and hyperphosphatemia, we will see in hypophosphatemia case that patient may have osteomalacia, muscle weakness, bleeding disorders secondary to platelet impairment, anemia, and leukocyte alterations. And one of the most common causes to cause this, it's antacid abuse. So we all love TV commercials and advertising all over the counter and prescription drugs to consumer. However, if patient has untreated gastroesophageal reflux, and Tums becomes the answer, So at that time, antacid will bind significant amount of phosphate and result in hypophosphatemia. So patient may present with muscle weakness, and something so innocent as antacids may result in complete energy metabolism dysfunction. It may result in muscle weakness of respiratory muscles, respiratory failure, and cardiac arrhythmias and death. So osteomalacia again may occur as a response to low phosphate level, and again low phosphate level can result from antacid abuse, one of the common things. And hyperphosphatemia is elevated level of phosphate, and at this time what can happen, phosphate goes with the calcium, and when phosphate goes with the calcium, so hyperphosphatemia can be related to hypocalcemia. So basically this may include, to fix this may include the treatment of hypocalcemia. So remember that the equations we mentioned before, but again high phosphate levels are related to low calcium levels. To make long story short, the symptoms will be the same as symptoms of hypocalcemia because it always correlates together. But one of the things I want to mention is if hyperphosphatemia continues, or it's possible that calcification in places that we don't need may occur. And by places we don't need, we mean lungs, kidneys, kidney stones, and even joints. How to treat this and what to do in this situation and hyperphosphatemia. Of course, again, you'll never go wrong by saying that let's treat the underlying condition, let's treat the source, but at the same time, aluminum hydroxide may be administered, and aluminum hydroxide is one of the antacids you can buy. So you treat it to reduce the phosphate, and you're doing it in GI tract. Okay. Aluminum is a good drug in this aluminum hydroxide, but it can be still resulting in deposits in central nervous system. So the science keeps developing, and there are other binding agents again, but aluminum is still possible to use. But again, to finish this topic of hypophosphatemia and hyperphosphatemia, please remember that the main thing here, main objective here in treatment, to treat the underlying source, because these disorders are usually consequence of something else that resulted in alterations of phosphate level.